So funny thing is that the diaphragm actually develops in the neck. Can you imagine that? And then it descends to its adult position between the thorax and the abdomen. So I'm going to make a simplified diagram that this is the thorax and the abdominal cavity of the baby embryo. It's simplified, okay? That's the caudal rostral end of the embryo, and that's the caudal end of the embryo, bottom end of the embryo. Now, first, I want to tell you about something which is called somite. Have you ever heard about somites? What's somites? Okay, so in the beginning, embryo was just 2 layers, like a sandwich, okay? Sandwich but no cheese. There's no cheese in there. We talked about it, thorax, remember? The bilaminar disc. There are just 2 sandwiches. It's a single sandwich, but nothing in between yet. The layer, of course, there's a layer on top and layer below. And there are cavity on top and there's a cavity below. Okay, the cavity below is called yolk sac. And the cavity above is called amniotic cavity. Amniotic cavity. The layer which faces the amniotic cavity, this one, is called epiblast. Right? And the layer which faces yolk sac is called hypoblasts. So epi-hypo. At this stage of development, the embryo is said to be bilaminar, meaning have 2 discs, 2 layers. But then, from the epiblast, cells starts proliferating and move in the middle. Okay, some of the naughty cells from the epiblast move down below and starts proliferating down here to form a middle layer. Which is called mesoderm. So mesoderm is derived from epiblast. The word meso means intermediate or in the middle. That's why they call it mesoderm, because there are just cells in the middle. Okay. But once this trilaminar disc forms, the epiblast becomes ectoderm and the hypoblast becomes endoderm, and in between mesoderm. And that's how the 3 germ layers cells develop. Ecto, meso, endo. Now this mesoderm, in the center there's notochord. I'm not going to go into details of that, but there's notochord here in the middle. Just besides the notochord, there are 2 layers or 2 masses of cells which develop, which is called paraxial mesoderm. And then there will be 2 plates like this, which is called lateral plate mesoderm. It has a somatic layer. So it's called somatic layer of lateral plate mesoderm. And here we have splanchnic layer of lateral plate mesoderm. All of this mesoderm is called intraembryonic mesoderm because it's inside the embryo. But there's also mesoderm outside called extraembryonic mesoderm. So in the exam, they may tell you intra or extraembryonic mesoderm. But just know that what we need to know that most things develop from the intraembryonic mesoderm. Alright, okay, so again, the mesoderm, when it develops, in the center there is notochord. Just besides it, there is what? Paraxial mesoderm. And just besides it is called, in total, lateral plate mesoderm, which has 2 horns, a wing facing the ectoderm called somatic layer, and a wing which is toward the endoderm, which is called splanchnic layer. Now, from this paraxial mesoderm, essentially this is a cut section, but in reality it's a column, right? It's a column like this. It's a column. It's a continuous column of mesoderm called paraxial. The notochord is over here. The notochord is here, which is, we talked about notochord a lot, right? Remember this one, which gives the nucleus pulposus and helps with the development of the neural tube, right? There's of course another column over here on the other side. Now this continuous column will be it will undergo segmentation. It will undergo segmentation to form segments. These segments, these segregated segments, are referred to as somite. So what is somite? Somite is simply the segmentations that comes from the paraaxial mesoderm. Each somite have cells which will gonna form muscles. This is called myotome for muscle, myotome. And there are cells which will develop bone and cartilage and tendons, which is called sclerotome. Sclerotome. The word sclero means skeleton. It means skeleton, bone and cartilage. That's why they call it sclerotome. When we talk about the skeleton of the eye, which is the sclera, we call it sclera because it's the skeleton of the eyeball, right? So sclerotome. Sclerotome gives bone and muscle, bone and cartilage, sorry. And there's other cells which are called dermatome. Dermatome, which is gonna form the epidermis of skin. The dermis of skin. Epidermis comes from ectoderm. So dermis of skin comes from dermatome of mesoderm, of paraaxial mesoderm, the somites. Each somite will give different stuff depending on the level, and the somites will be in sections like C1, C2, C3, you get me? Now from the C3, C4 and C5 somites, the diaphragm will develop. The diaphragm, the origin of the diaphragm is which somites? C3. Does that ring any bell? Right? The same nerve root for phrenic nerve. This is why the diaphragm develops in the neck region, and that then it descends down and it drags the phrenic nerves with it. That's why phrenic nerve is very long. It starts in the neck, traverses the neck and thorax and diaphragm to supply it. This is why it's very long, right? Okay, so what happens exactly? What happens? Now let me tell you what happens. For sake of simplification, I'm gonna remove these, and I am going, imagine this is side view, and this is the body cavity of the baby. Okay, that's the body cavity of the baby, which we call coelom, intraembryonic coelom, whatever. And this is supposed to be what's gonna be thorax, suppose, and this is abdomen, and this is neck region, suppose. Now already there is a septum which develops from the lateral body wall, which is called septum transversum. I'm gonna give it a different color. Septum transversum. Okay, it's in the neck initially. It's called septum transversum. This septum transversum, what happens? The myotomes, these cells, the myoblasts, which are going to give the muscle cells, they will migrate. They will have a trip from C3, C4, C5 myotomes. They will move and kind of invade or infiltrate the septum transversum. It will infiltrate the septum transversum, and it will be very, very rich in muscle cells, right? Cells which are gonna form muscles. Is that right? And you know, to give you a better idea, I'm gonna give you a superior view. Okay, this is the body cavity. This is the body cavity, suppose. Septum transversum does not cover this entire opening actually. Okay, does not cover this entire opening. What happens is that we have from posteriorly here is the dorsal mesentery of the foregut, which hangs the future esophagus here, okay, and connects it to the back wall of the body. And we have septum transversum over here. This is all septum transversum. And we have two gaps between the septum transversum and the foregut mesentery, here and here. They are posterolateral. These are canals. I'm going to come to them. They are very important for us. I'm going to come to them later. And the rim here is filled with infoldings of the lateral body wall. What I mean, that if we do another diagram here, that's body wall. This is septum transversum. Now this body wall laterally will infold. It will infold on its own, on itself, or upon itself. It will be like this. I'm going to draw it here. It will be like this. It will infold in this fashion, and it will close off, right? It will close off and will keep descending, such as that it will eventually look like this. It will look like this. In the end, it will look like this. You get me? Any bell? Any bell ringing? What's this? The costodiaphragmatic recess. We talked about it in thorax. So the costodiaphragmatic recess is formed why? Because there is infolding from the lateral body wall during the development, and that forms these two recesses. It means this part of the diaphragm, the peripheral part of the diaphragm, the very rim, is not from septum transversum. It is from infolding from the lateral body wall. This is why they have, as I told you, different sensory supply, the lower 6 intercostal nerves, remember? So what we know so far, that diaphragm has how many components? It has a component peripherally, which is from the infoldings of the lateral body wall all around, and it has a central component, which is the main one, that's the septum transversum, and it has a component on the back. This component on the back is the mesentery of the foregut mesentery, and it has two components posterolaterally, which are canals that will be closed by a membrane. I'm not gonna say the names now, just remember we will call it the funny membrane, because it can do a lot of funny things. We will call it the funny membrane. So there's the funny membrane here. So components of diaphragm is what again? Septum transversum, lateral body wall infoldings, dorsal mesentery of foregut, and funny membrane. 4 components. And remember the C3, C4, C5 somites, they've donated muscle cells, and these muscle cells will originally infiltrate the septum transversum. But you will say, how is that possible? Because in anatomy, I have studied that the muscle part of the diaphragm is the peripheral part, and the central part of the diaphragm is the tendon part. So how come muscles are here in the center? I will tell you, they will migrate. They will migrate and leave the septum. They will break. They will have a bad relationship, very toxic relationship with septum transversum, and they will just move to other parts. They will move to the lateral body wall infoldings. They will move to the mesentery of foregut. They will move to the funny membranes and leave the septum transversum. Tricky, very bad. They will leave septum transversum and move here, the muscle cells. Oh, very unloyal. Loyalty issues. Okay, Funny membrane also, it makes relationship with every one of these muscle cells. Very bad muscle cells, very naughty muscle cells. Relationship with lateral body wall enfolding, right? Relationship with the funny membrane, relationship with the dorsal, the mesentery of the foregut. And of course, must be very sad. Septum transversum must be very sad. Tears as well. So you get the idea of how diaphragm develops, right? Now, I want to talk about specifically about this funny membrane because it comes in every exam. Now let me tell you something. In simple way, this is body cavity. Now the thorax used to be called primitive pericardial cavity. Primitive pericardial cavity. This thorax cavity, all of it is called what? Primitive pericardial cavity. Pericardial cavity. And down here below is the abdomen. They call it primitive pleural cavity. Peritoneal cavity. Primitive peritoneal cavity. And we have our friend here, septum transversum in between, right? Septum transversum. There is a canal posterolateral to septum transversum, which is this canal. I made it too small. I'm gonna make it bigger so that, you know, drawing is the best thing because it's the language of cavemen, right? It's the language of cavemen. It is, you can understand anything from drawings, even when you don't have the language, right? The first ever texting that have occurred in history was a caveman who went to a rock and wrote, "I am here." He wrote on the rock, I think, "I am here," or "My name is that." And then I don't know how much time passed, but another person came and basically did "seen." He wrote like, "I saw it." He did these two lines. So they understood each other, right? Okay. Body of cavemen. So, language of cavemen. This is a canal. This is a canal. Now this canal is open. It's open superiorly. It's posterolateral to the, it's here. It's this canal, guys. It's here. Here and here. It's paired canal. Posterolateral to septum transversum. On either side of the foregut mesentery. But this section, I took it on the side here. You get me? The section is here. So we look here. This is primitive pericardial cavity on top and primitive peritoneal cavity down below. And there's a canal between them. If you have to name this canal, what are you going to name it? Peritoneal canal. Simple, right? Peritoneal canal, because it connects primitive pericardial cavity to the primitive abdominal cavity or peritoneal cavity. Now there's something you have to know. This something that you have to know is that the foregut tube, this is foregut tube, it will give rise to something called the lung buds or the tracheobronchial diverticulum, tracheopulmonary diverticulum. What's that? This thing will give rise like this. I'll show you. I'll give it a different color. And another tube forms here. You get me? Another tube forms here. This is foregut tube, which is going to become esophagus, this specific part, foregut tube, and it gives rise to trachea in front of it. Initially there's a communication, but then it cuts off. By the way, if this communication does not cut off, we will have various forms of tracheoesophageal fistulas, right? But normally it should close. Anyway, this superior part will give trachea, but down below it will divide into two buds like this, or two parts, which is going to be lungs. These two parts will ingress. These two parts will ingress here. They will grow here. They will grow inside of the pericardio-peritoneal canal. It will grow inside pericardio-peritoneal canal. So it is like this. This is one pericardio-peritoneal canal. That's the other pericardio-peritoneal canal. And here is septum transversum in between them, right? In front, I mean. And on the back is the esophagus, or the foregut tube. And here is the trachea forming over here. And there's the buds. They will grow. One grows here, and the other grows on the other side as well, right? And they want some privacy though. They are very shy. They want some form of privacy. Get me dashed line like it's inside now. They want some form of privacy. So they will cover themselves. They will cover themselves by a membrane. A membrane will develop here. A membrane will develop here. It will close this door, right? It will close it because they want to grow, right? Privately. They are shy buds. But this shy bud also have another opening below. It's, as I told you, it's shy. It doesn't want anyone seeing it doing funny things. So another membrane grow here. So if we go back to our previous diagram, the lung bud has grown here, but it covered itself from a membrane on top and a membrane below. Membrane on top and membrane below. Now, the pericardio-peritoneal canal, this canal, is now housing the lung. Is that right? This canal is now housing the lung. So, people have looked at this and said, that's, I think this name no longer really fits that much because it is no longer a canal. It is just a house for the lung to grow. So we're just going to call it primitive pleural cavity. And we're going to call it primitive pleural cavity. Here's when things get very interesting, guys. Since this is the future pleural cavity, which is essentially the same as pericardio-peritoneal canal, this membrane, we're gonna name it what? Well, we changed the name. We cannot call it pericardio-peritoneal canal primitive pericardial cavity membrane. That will be very long, right? Because it's a membrane essentially between the canal and the primitive pericardial cavity. So we're not gonna call it that. It's gonna be a long name. So simply we're gonna, since this is gonna be house of lung, so that's pleural cavity, so we're just gonna call it pericardio pleural membrane. We're gonna call it pericardio for the primitive pleural cavity, pericardio pleural membrane. This membrane has a very interesting story. I will tell you about it later. Is that right? Because it's between primitive pericardial cavity and now we call this canal as pleural cavity. So it is called pericardio pleural membrane. And if we want to name the membrane down below, again, we're not going to call it pericardio peritoneal canal membrane, whatever. It's going to be confusing. So we're just going to call it, since this is primitive peritoneal cavity, we're going to call it pleuroperitoneal membrane. We're going to call it pleuroperitoneal peritoneal membrane. Now it's confusing, guys, because in the exam that's confusing. So it means please look at the difference very logically. Pleural cavity, peritoneal cavity. So they talk about this one, the below one. Pericardio means primitive pericardial cavity. Pleural, should be plural. Yeah, plural. They talk about this one. So we call it pericardio-pleural membrane, or pleuropericardial membrane, or pleuropericardial fold. Same. You can call membrane, you can call fold, it's the same structure. Now what's going to happen? Well, the thing is that, as I told you, septum transversum will start descending, isn't it? And towards its normal adult position. So focus with me, it will descend to this location. Suppose this is the new location of the septum transversum. And the lungs keep growing. The lungs will keep growing. This membrane, which we have called it pericardio-pleural fold, or pericardio-pleural membrane, or pleuropericardial fold, whatever you like, it will be slanted like this. It will be more vertical. Okay? It will, as the lung is growing and the septum transversum is descending, this membrane will tilt like this. And the lung will be essentially behind it. So I will draw the new position here. I'm going to remove all of this. And we're going to draw the new position of that. So lung have grown really well. Okay, have grown very, very well, the lungs. This is the lung. The septum transversum have descended. And the membrane, it's like this now. The membrane is like this, you get me? And this is the pericardial cavity, and this is the pleural cavity, which used to be pericardio-peritoneal canal, and this is the membrane between them, pericardio-pleural membrane or pleuropericardial membrane, whatever you like. And below, still the same situation, it's closed. By which membrane? Pleuroperitoneal membrane. Pleuroperitoneal membrane. Now, what's going to keep happening is that this lung will keep growing anteriorly and it will sandwich the heart. Let me show you what I'm talking about. So here in this diagram, I'm going to draw a diagram that we're looking from front. We're looking anteriorly. You're looking anteriorly. All right. So this is the septum transversum, or now it's like diaphragm now, right? And here is our beautiful heart. That's our heart. The lungs were behind and the membrane was in front of them, right? The membrane, which was called pleuropericardial membrane, as we've agreed. This is the membrane. I'm going to make it simplified. It's now vertical, right? It's now almost. That's also the membrane from the other side. And the lung is behind the membrane. So I'm just going to draw the top of the lungs here so that you can imagine that the lungs are behind. But as the lungs are growing, they will close these two membranes like a book on the heart. These two membranes will close like a book on the heart. So what's going to happen? Let me draw another diagram where it is a little bit more advanced. This is the heart. This is the whatever. And septum transversum. And here we have the membranes are now in front of the heart. You get me? They are like this, slanted like this. And they are covering the heart, and the lungs are ingressing into this location. Right? The lungs are ingressing into this location. Let me remove all of this, yes, to make you know what I mean. You get me? They have pushed the membrane. They are growing towards our face now. The lungs are moving towards us, like this, towards us. And the membranes are being pushed onto the heart, and they will eventually close on the heart. So eventually the heart will be like this. Okay? It's completely enveloped in the membranes. Completely enveloped. This will form your beloved fibrous pericardium. This will form your beloved fibrous pericardium. So fibrous pericardium comes from what, if they ask you? Well, it is coming from the membrane which was on top of the pericardio-peritoneal canal, which is now called pleural cavity, which now then we should call this membrane as pericardio-pleural fold or pericardio-pleural membrane, or the reverse, pleuropericardial, whatever you like. So if there's a defect in this structure, we know the structure forms the fibrous pericardium. If there's a defect in this structure, it means there will be defect in the fibrous pericardium. It could be complete congenital absence of the fibrous pericardium, right? Or partial, which is more common. So you will find this is fibrous pericardium, like this, and the heart is inside, right, of the fibrous pericardium. There will be defect or like this, a defect like that, right? This is partial defect. This defect, lung may herniate through here, through the defect into the pericardial cavity, which is rare. This defect is so rare anyways, right? This defect is called fibrous pericardial defect, which can be congenitally absent completely or partially, which is more common, especially partially more common on the left side of the heart. This will make the heart be pushed. So the left side is absent and the heart will be pushed leftward. This is called levoposition. Levoposition. Okay, that's so rare. Very, very rare. The more important, more common situation is the membrane here, below, which we call it what? Pleuroperitoneal. Pleuroperitoneal membrane. Peritoneal, right? Pleuro for this cavity and peritoneal for this cavity. So pleuroperitoneal membrane. A defect in this one, they will ask you this in the exam. Simply what happens is this membrane does not develop well. It develops with gaps in it. It does not develop well. So there's maldevelopment of the pleuroperitoneal membrane. It does not develops very poorly, and a communication remains between the pleural cavity and the peritoneal cavity. This is especially true on the left side. So it will be posterolateral and to the left defect. If you move to this diagram here, there will be a big defect. Usually it's so big in this region, a huge defect, very considerable defect in this region, through which bowel loops and things herniate to the left side of the chest. On the left, it's far more common. Some authors say it's at least 10 times more common on the left compared on the right, at least like 10 times more common on the left. Why it's not common on the right, well, nobody really knows, but some people say because the liver is on the right, so it can seal this. Even if the membrane does not develop well, it makes a seal, then which later heals. So it's so uncommon to see it on the right, but whatever, nobody really knows for sure. But what we know for sure is that it's much more common on the left. So they will ask you a lot of questions about that specific topic. I will show you some example questions from the exam, okay? Okay, dokie, all right. So we talked so many things about it. Sometimes the diaphragm fails to fuse with the sternum on the back here. So there will be a little defect over here in the diaphragm. Tiny defect over here, and this defect is usually so tiny, it's anterior and most commonly on the right, and we call it Morgagni hernia. Morgagni hernia. It's rare on the left, Morgagni, but if it occurs in the left, some people call it Larry hernia. Larry hernia. So if it's on the left, Larry, if it's on the right, Morgagni. Morgagni hernia, most common organ that comes here, because it's anterior, most common organ is the transverse colon, and it's mesocolon, the transverse colon. But it's usually very tiny to accommodate anything. But if it does accommodate something, most common organ is the transverse colon because it's anterior. I think we talked enough about the diaphragm. We know everything about it right now. What I want to show you something, which is this imaging. This is an imaging of a pregnant woman with poctalic hernia. The defect that I told you about posterior to the left is called poctalic hernia. Failure of which membrane to develop? Pleuroperitoneal. Poctalic, I think it's like that hernia. Poctalic hernia, unfortunately, it's much more common compared to Morgagni and everything. That's a baby. She's a pregnant woman. This is the head of the baby. This is the body of the baby. This is the column, vertebral column of the baby. This is the diaphragm of the baby. And this is the lung of the baby. This is it's a normal right lung. But on the left, that doesn't really look like a lung. These are bowel loops. So there's a lot of bowel loops on the left side. The issue with that is that the left lung will not develop well. It's called pulmonary hypoplasia because there's no space for it to develop. Pulmonary hypoplasia. The bowel loops herniate into the cavity that the lung was supposed to grow in, but it doesn't. So most baby die because of this thing. Pulmonary hypoplasia. Most baby die because of what? Lung failure. Respiratory insufficiency. Not because of the hernia itself, like per se. It's really the effect on the lung what kills. All of what we talked about in the diaphragm from A to Z is so essential for the exam purposes. Let's take some examples. This is one simple question. Well, as you can see, they tell you which one is like main muscle of inspiration. No fun in saying, right? It's diaphragm. Let's see the next one. Which of the following, they tell you, which of the following give rise to the crura of the diaphragm? Crura of the diaphragm. Septum transversum? No. Mesentery of esophagus? Yeah, kind of. Not all of it. Lateral body wall? No. Pleuroperitoneal membrane? No. Dorsal mesentery of foregut? It's a more accurate answer because at that time it's still not esophagus. It's called foregut. Because as I have shown you here, I think I forgot to mention this specific point. I'll show you here. Do you see this one? When the muscle have left the septum transversum and moved to the various other parts, when it moved to the mesentery of the foregut, it will form the crura of the diaphragm. So crura of diaphragm are derived from this particular part. Okay. Let's see the next one. Which of the following nerves supply the diaphragm? Before we see the question, what supplies diaphragm? Phrenic nerve mainly, C4 mainly, and that's sensory and motor, but peripheral sensory is lower 6 intercostal nerves. Okay. Always try to answer before you read the options. Greater splanchnic, lower 6 intercostal nerve, yeah, it does. Upper 6 intercostal nerve, no. Lumbar splanchnic nerve, no. Ilioinguinal, no. So it is B. Lower 6 intercostal nerves. Lower 6 intercostal nerves. Let's see another one. Which of the following structures contribute to the formation of the diaphragm? Lateral plate mesoderm. No. Superior part of septum transversum. Yeah. Inferior part of septum transversum. Pericardio-peritoneal canal. The canal itself, no, but the membranes, yes. None of the above. So it's a difficult question. There is something I want to add about the septum transversum. The septum transversum have upper and lower parts. This is the body cavity. This is the septum transversum. The upper part of the septum transversum really does contribute to the diaphragm, but the lower part of the septum transversum actually contribute to liver and the ventral mesentery. Because why? The liver will grow into the lower part of septum transversum. That's foregut tube. The liver will grow here, along with the gallbladder. As it grows here, most of the lower part of septum transversum disintegrate, except a thin fold here and surrounding the liver. So it will form the ventral mesentery and contribute to the hepatic structure, the capsule or the outer covering of the liver. But it will not contribute significantly to the diaphragm itself. So the best answer for this question is superior part of septum transversum, right? Because they want which one really contribute. The lateral plate mesoderm is not, as we said, it's paraxial mesoderm. The inferior part of septum transversum, as I just told you, and pericardio-peritoneal canal, no, but the pleuroperitoneal membrane, yes. The pleuroperitoneal membrane, which closes the canal from below, yes. Okay, let's see another example. A large posterolateral diaphragmatic hernia present at birth is caused by which of the following? As we said, posterolateral means it's bogdalic. Posterolateral means it's bogdalic, so it's usually on the left. So which canal is problematic? Pleuroperitoneal canal, membrane or fold. So it should be failure of closure of the left pleuroperitoneal membrane. Failure of closure of left pleuroperitoneal membrane. Let's see the next one. A one-day-old infant is born with severe respiratory compromise, that's at birth. On examination, he has a scaphoid abdomen, bowel sounds are audible on the left chest, and cardiac apex beat is displaced on the right side. So again, this is a diagnosis of bogdalic. Because when herniation occur on the left, you will hear bowel sounds on the left, and they will push the heart on the right, or towards the right. So what do they want? They say situs inversus, septum transversum defect, pleuroperitoneal membrane defect, cystic fibrosis, Morgagni, no. So it is option C. Same question, but here it's direct, and here it's in a clinical scenario. The scaphoid abdomen is because when bowel move to the chest, there's nothing to fill the tummy. So it appears like this, right? Scaphoid appears like this, the tummy, depressed. Let's see another question. Which of the following structures pass through the esophageal hiatus of the diaphragm? Esophageal hiatus. We know esophagus and the vagus nerves. So they say left vagus, yes. Left phrenic, no. Right phrenic, no. Azygos, no. Hemiazygos, no. So left vagus. Simple. Let's keep going. Which of the following is true regarding the inferior vena cava? It passes through the muscular part of the diaphragm at T8 level. This is wrong, because it's not through the muscular part. As I told you, it's through the caval opening in the central tendon of the diaphragm, not through the muscle part, through the tendon part. Is that right? It is anterior to the liver. It's behind it, actually. It enters the thorax by passing through the central tendon of diaphragm. Yep. Although here in option A, they are very sneaky. They give you the correct level, but wrong part through which it passes. It's posterior to the right renal artery. Not really. It forms when the internal and external iliac veins join at L5. It should be two common iliac veins at L5. So it is what? The correct answer is C. Let's move. Let's see another example. So a 40-year-old man develops sudden dysphagia after swallowing a piece of meat. CT scan shows a foreign body lodged at the site where the esophagus traversed the diaphragm. the endoscopist would expect to find the foreign body at which distance from the incisor teeth? I told you earlier that the esophagus passes through the muscular part of right cross of diaphragm, which is at approximately the level of T10, but I didn't tell you the endoscopic marking in this lecture. I've told you in another lecture, but not in this. You know, from the incisor teeth, at a distance, so if we'll revise quickly. From the incisor teeth until the beginning of the esophagus is 15 centimeter. This is called cricoesophageal junction. At approximately 25 centimeter, we have the constrictions imparted by the left bronchus and arch of aorta. So they call it aortic and bronchial constrictions. The aortic constriction is a little bit up, it's like around 23, 22, and the left bronchial constriction is a little bit down, like 26, 27, but generally we say it's 25. And at 40 cm, it passes through the diaphragm. So the answer here is 40 cm. Let's take another example. An 82-year-old woman presents with intermittent dysphagia. Endoscopy confirms the presence of mild stricture at the esophagogastric junction. The esophagus normally passes through the diaphragm at T10. But remember, the esophagogastric junction, as I've told you in the previous lectures, is at T11, not T10. But here they don't want the junction, they want where it passes through diaphragm. Let's see another example. A 2 months old infant is troubled by recurrent colicky abdominal pain and intermittent intestinal obstruction. On imaging, the transverse colon is herniated into the thoracic cavity through a midline defect. What is the most likely defect in a 2-month-old child? Is it Bogdalic? No, Bogdalic is very large and posterior and to the left usually. Morgagni, yes. As I told you, Morgagni usually includes the transverse colon. Litters hernia, that's not it, it's a different topic. We'll talk about it in hernia. Paraesophageal hernia, no. Hiatus hernia, also no. We'll talk about these hernias in detail in hernia lecture. Okay. Let's see a last example. The muscular portion of the diaphragm develops from which of the following? Cervical somites C1, C3, cervical somites C3 to C4, right? It is in the cervical somites from C3 to C4. So I think that's a lot to take in one lecture, but I think it's the very, very, very important part to understand. I hope you've enjoyed it. I will see you soon in another lecture. Thank you so much for listening and best of luck.